Ready? Okay. Mr. Chairman, you can go on.
Hi, everybody. I'm Dr. Hong Yi from Mackay Medical University and Mackay Memorial Hospital, located in New Taipei City, Taiwan. It's my great honor and pleasure to chair this APSC Crowd Forum of Cardiovascular Disease Series. And today, we will have a very important issue for the lipid guideline update. The theme of this symposium is named Purge from 2026 ACC AHA ADA Dyslipidemia Guideline regarding screen earlier return of LDL, non-HDL cholesterol goals. Along with me is Dr. Tachapong Nagamus from Thailand. Dr. Tachapong, would you like to introduce yourself a bit?
Hi, I'm very excited to be here. I've never been in one of dyslipidemia conference before. I'm mostly electrophysiologist, so I'm glad to join today. I'm looking forward to learn a lot from all the experts.
Okay, thank you. I think we will have 5 speakers. For the first 3 speakers, I will introduce them. And for the last 2, just let Dr. Tachapong to do the task. Now I will have some annotation regarding this symposium. Based on the prevention equation, the 2026 ACC/AHA ADA Dyslipidemia Guideline have renovated tremendously the lipid management strategy in primary and secondary prevention of ASCA, and re-embrace the therapeutic goal of atherogenic lipid, including LDL cholesterol and non-HDL cholesterol. In today's webinar, we will go into directly detail and comment about the strategy of lipid screen and therapy in primary prevention and of ASCA in young in young adult 19 to 39 years old, and in adult over 40 years male, and over 45 years for female without ASCA, as well as secondary prevention of adverse events in adults with clinical ASCA, particularly the target goal LDL and non-HDL cholesterol reduction. In addition, we will look into the more complicated conditions in whom with planning pregnancy or during pregnancy, and in whom with diabetes mellitus have a years age range from 20 to over 75, or with clinical atherosclerosis. So I think the topic of this symposium will cover almost all adult age range. Now let me have some declaration. The content of the webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and the opinion expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. And I have some housekeeping messages. The live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and the YouTube page as well. Now let's get started. The first speaker is Dr. Lo Wan Jia from Singapore. She is currently a senior consultant endocrinologist, head of the lipid unit in Changi General Hospital, Singapore. Dr. Jia, please.
Okay. Thank you so much for the invitation to speak today. It's going to share my slide. My name is Wan Jia. I'm a senior endocrinologist working in Changi General Hospital, Singapore. So the topic assigned to me is on 2026 American Lipid Guidelines that just published last month to check regularly, manage early to reduce atherosclerotic cardiovascular disease in young adults. Specifically, I'm looking at the 18 to the 40-year-old, looking at the goals and also looking at considerations of treatment. So from the lipid guideline that was just published by America, the top take-home messages, which they have listed from 10, the top one that they wrote was, treat dyslipidemia earlier to reduce lifelong prolonged exposure to atherosclerotic lipoproteins. Health behaviors counseling to support lifestyle optimization should start young, with early consideration of pharmacotherapy in youth with FH, so familial hypercholesterolemia, and in young adults with LDL that's more than 160 mg per deciliter, which is 4.1 per millimole per liter, or if they have a strong family history of premature ASCVD. Now, screening lipids at a young age, right? What they mean is at age 19, and then after that, at least every 5 years thereafter. This is to identify ASCVD risk and allows earlier treatment. This is a class 1 recommendation where the benefit outweighs the risk. A level B NR, which means that moderate quality evidence. So although there are no clinical trials to show benefits or harm of lipid screening in younger adults to reduce ASCVD events, this is a strong recommendation by the American Lipid Guidelines because we know that the longer the duration of exposure to high LDL cholesterol concentrations will be an important driver of a lifetime ASCVD risk. That's why screening early allows detection for a few things. 1, to find out secondary cause of high LDL cholesterol. 2, to look for monogenic disorder. Particularly, we're looking at familial hypercholesterolemia as a disorder where they have genetic mutations that affect LDL cholesterol clearance with a high LDL cholesterol for life. And 3, allows for prevention and treatment of ASCVD. But the first and foremost is always going to be diet, physical activity, weight optimization, lifestyle changes to have a healthy life. And all this is strongly recommended for young adults onwards. Well, let's see what's actually happening in USA currently. So this is a paper published by Zhang et al. In JAMA in 2020. And they look at the distribution of LDL cholesterol in the young age of 20 to 29 and 30 to 49. You see that there's about 5% of young American adults, right, with LDL cholesterol that is more than 160 mg per deciliter or 4.1, 4.2 millimole per liter. Whereas if for the 30 to 49-year-old range, there's about 10% of them with LDL that's high. And more than 50% of young adults in America actually have LDL cholesterol more than 2.6 millimole per liter between the years of 2015 and 2020. And less than 2.6 millimole per liter would be something of healthy. So they're trying to say that half the young population adults already have unhealthy cholesterol levels. This trend of high LDL seems to be improving with time. So on the second graph here, looking at the time period from 2003 and after that 2009, after that 2015, we see that there's a slight decrease in people who have high LDL of more than 160 mg per deciliter or 4.2 millimole per liter in this age range of 19 to 39. And then we see that there's more awareness and screening among youth with time in the third graph here. Younger age, lack of insurance, or lack of a routine place for healthcare were associated with lower awareness of high cholesterol among the young adults. What about Singapore data? So here I pulled from the internet is a Singapore's National Population Health Survey published in 2024. You can see that when you divide it by the age range from 18, 30, 45, and so forth, in the box in red here, we see that actually there are quite a lot of people who have prevalence of hyperlipidemia, in other words, hypercholesterolemia with an LDL cholesterol more than 4.1 millimole per liter. So 10.9% of 18 to 29-year-old in Singapore actually have hypercholesterolemia. 16.3% of 30 to 40-year-old actually have high cholesterol LDL more than 4.1 millimole per liter. What is also striking is that the proportion of undiagnosed hypercholesterolemia appears higher in younger age group. Highlighted in yellow here, you see that 85% of residents were undiagnosed with high cholesterol in the 18 to 29-year-old range. Well, this is not surprising because our health screening program tends to occur at 40 and above. So that's why there are less people who are undiagnosed high cholesterol in the older age. Well, what about healthcare in Singapore. So I've just completed my study called LPACO, Lipids in a Healthcare Worker in Singapore, where we have 2,000 healthcare staff, so doctors, nurses, and everyone else working in healthcare. And here I show you a paper that we published here. And you can see that by the age range of 20 to 29, 30 to 39, 40 to 49, and 50 and above, that the LDL cholesterol does go up with age, and so does non-HDL cholesterol. And that there is some difference between different ethnicities living in Singapore. So as Chinese, Malay, Indian, and Filipino, the Indian tends to have higher cholesterol compared to the rest of the ethnicities. Coming back to the 18 to 29-year-old American recommendations as per the lipid guidelines. So there are no RCTs of lipid-lowering therapy in young adults, specifically looking at 18 to 29-year-old to look at efficacy. The reason is because there need to be a very long follow-up for RCTs to really show benefit. Next one, the use of lipid-lowering therapy in young adults of this age range with high atherogenic lipid burden and a high burden of risk enhancers is a matter of clinical judgment and patient preference in absence of available evidence. This means that if you suspect this patient has got a genetic disorder that making high LDL for life, like familial hypercholesterolemia, polygenic hypercholesterolemia, or other causes, then it is important to start treatment, but you should discuss this with your patient. The USA has come up with a new risk equation, as Dr. Ye mentioned just now. So this is a prevent risk equation. They look at 10-year as well as a 30-year prediction from the age of 30 onwards, so 30 to 79 years old. And this risk equation will include age, BP, GFR, HDL, diabetes, but interestingly also include urine ACR, HbA1c, and the zip code of where they live in. So this is helpful for anyone who age 30 and above living in America. As per the American lipid guidelines, I summarize here the lipid goals for ASCVD risk reduction. So we will aim for LDL cholesterol less than 2.6 or corresponding non-HDL cholesterol less than 3.4 millimole per liter as a primary prevention for anyone who has a prevent ASCVD of less than 10% predictor risk. For a person who has severe hypercholesterolemia, which means the LDL is more than 5, but they don't have FH, then you can actually aim for LDL cholesterol of less than 2.6. A diabetes patient, right, without any ASCVD risk factors or diabetes-specific risk modifiers, which means that don't have albuminuria or other complications, then LDL cholesterol less than 2.6 is sufficient. The second group is when you aim for LDL cholesterol less than 1.8 millimole per liter or corresponding non-HDL cholesterol less than 2.6 millimole per liter would be people who are at a slightly higher risk. For the primary prevention group, this would be a prevent ASCVD score of more than 10%. For severe hypercholesterolemia, there will be someone suspected with FH, or they have ASCVD risk factors like hypertension or diabetes, or if they have subclinical atherosclerosis. And next would be diabetes with ASCVD risk factors. LDL less than 1.4 would be someone who has severe hypercholesterolemia or a heterozygous FH with clinical ASCVD. As for all patients with clinical ASCVD, we will aim for LDL cholesterol less than 1.4, and the lower the better. Talking specific about diabetes, for the age range of 20 to 39 years old, the American Lipid Association mentioned as a primary prevention would be, when would you start moderate intensity statin? The answer would be long duration, which means that more than 10 years of type 2 diabetes or more than 20 years of type 1 diabetes, the presence of albuminuria or GFR less than 60, retinopathy, neuropathy, or ankle brachial index of 0.9. And also coming back to the further lipid goals, right, for ASCVD risk reduction, they look at subclinical atherosclerosis presence, and that also will determine how far you want to intensify your LDL treatment, depending on the calcium score, high triglyceride levels, or having clinical ASCVD. Basically, the lower the better, even for young adults. And one of the tests that one can do as part of lipid screening will be total cholesterol, HDL, triglyceride as a standard lipid panel. What was interesting is that they mentioned about the estimated LDL cholesterol. The American Lipid Guidelines actually strongly recommend for Martin-Hopkins equation or the Sampson-NIH equation instead of the Friedewald equation. Especially if the TG is actually high, more than 1.7 millimole per liter, and LDL cholesterol less than 1.8 millimole per liter, or non-HDL less than 2.6 millimole per liter. This is actually more accurate, especially when TG is abnormal. It's important to remind our patients and our staff that there's no need to fast because LDL cholesterol does not vary very much between fasting and non-fasting state. And the postprandial increase in triglyceride are generally small. I personally feel that it's also important to actually do it as a non-fasting so that we know how high the triglyceride is on the times when they're not fasting. And I put in bold here in red on LPA because something very close to my heart is LPA testing. In all adults, measurement of LPA is recommended at least once in their life for ASCVD risk assessment. This is a class 1 recommendation, a level B moderate quality evidence. And since we're talking about LPA, I'll just show the Brussels International Declaration on LPA testing published a year ago by experts around the world, particularly of the Europeans. And this declaration on LPA calls for a few things. The integration of LPA testing and management into cardiovascular health plans, the investment in policy and programs in targeting LPA testing and management. The International Declaration also calls for incorporation LPA tests without fear of discrimination. This includes insurance implications, political commitment to mandate that LPA should be tested in all adults, and they also call for increased awareness of public and healthcare education. And I think what we are doing now as a webinar is an example of a healthcare education. Now, since 2017, there has been many guidelines, right? One after another, every single year, there's multiple coming out. They're all coherently and they're all recommending the same thing, which is LPA should be tested in all people who are at high risk of ASCVD. A few of these have now also called for universal testing, as per what the Brussels International Declaration is calling for. And since we're talking about LPA, I'll just show you a study that I published recently to show that a high LPA of 120 nanomole per liter, which is about 50 mg per deciliter in Singapore, actually affects 8.3% healthcare workers. This is quite big because actually diabetes prevalence in Singapore is only 8.5%. And actually healthcare workers actually tend to already be healthier, more health education wise. So we were surprised to find that 8.3% of us actually have high LPA. But having an abnormal LPA of more than 17 nanomole per liter or 30 mg per deciliter already affected 15.1% of us. There are new therapies that are coming out. They're now on the phase 2, phase 3 trials, and you can divide them into two groups. One is the RNA therapies, another one is the oral small molecule inhibitor. The oral small molecule inhibitor is quite interesting. Actually, it breaks the bond between the ApoA and ApoA and ApoB. And it is the only oral medication form that is actually on the trial that will be out first. I often ask people this in my talks. I do give quite a lot of educational talks. And I ask people, are you confident to manage LPA? And if you're not, you could actually do a study that I do here, which is you can scan the code on LPA to watch the Lilac education that I've done. And in return, you actually get a book that I created here. And this is a lipid webinar that was just done on the last Friday. It was really good. We had 1,500 people online, which is amazing. And we talked about the gender issues, about lipid cholesterol and LPA. And also we had a patient support event last Saturday for 300 plus patients came to learn about lipids. So there are more and more awareness and education about this in Singapore. Just want to end off talking a little bit about FH. In the Singapore, we have a study called a Singapore 10,000 patients, 10K study. And this is published by this group here, which is said that actually heterozygous FH affects 1 in 140 people, which is actually quite high because actually the world prevalence of FH is only 1 in 300 people. What's interesting for Asians is that they reported that 15% of people who have genetic defined FH actually also have the genetic mutation that make them more likely to have statin intolerance. And in Singapore, the national program that was launched by our government is a single criteria referral, very easy, which is LDL cholesterol more than 5.5 millimole per liter will get subsidized testing of FH of these 3 genes only. This started last year. It was in our news. And my tips of genetic testing on FH, right, would be a few of this. Number 1, we should recommend all our patients to have genetic testing if we suspect, especially if there was a family history of ASCVD or high cholesterol, or this person present at a young age with a cholesterol that's very high. And for Singapore, the subsidized, the low cost of testing is actually if the cholesterol is more than 5.5 millimole for LDL. But it's important for all doctors to understand that even people who are who score definite FH by Dutch lipid score or by Simon Broom score, the positive testing rate is still counts out to be only 60 to 70% of the patients. and the 30 to 40% did not harbor a pathogenic or likely pathogenic variant of genes of FH, nonetheless, we will still treat them as high risk and actually prevent ASCVD by lowering LDL cholesterol. The clinical diagnosis and family history is still more important than the diagnosis of genetic FH or phenotypic FH. So really try to ask a lot about family history. Examining for tendon symptomata also is very helpful. It implies it's been there for a long time, high cholesterol. And there are differentials to consider for high cholesterol apart from FH, and that could include phytosterolemia, polygenic forms, severe LPA, thyroid medications, and nephrotic syndrome. Or even a very low carb, high fat diet can actually cause that. And that patients and doctors can consider to refer to lipid specialists if, for very severe cases. And here is for people who are interested to hear more of my webinar. I do once a year or sometimes more than that. You can actually screenshot and do the QR code later. And with that, I finish my talk and I thank you very much.
Thanks, Loan, for the excellent talk. I think Loan provided very important and interesting data regarding Singapore situation. And after all the talk, we will have a panel discussion. We can discuss more at that time. So please preserve your question. Now we'll go to the second talk. It's going to the more middle-aged people, over 40 for men and over 45 for women. The second talk is given by Dr. Yas Musa from Jordan. He is senior international cardiologist at private sector. He also associate professor of medicine and cardiology, chief of cardiology in Jordan University Hospital, located in Amman, Jordan. His talk is entitled Dyslipidemia Management in Adults over 40 years for male and over 45 years for female with clinical atherosclerosis, Jordan's point of view. Dr. Iyas, please. Sorry, any signal?
Dr. Musa, please turn on your microphone. No, I don't think he's freeze. Okay.
Can you hear me now?
Very well, thank you.
Let me share my slides and please confirm that you can see my slides and the full presentation and hear my voice.
Your voice is okay, no problem. We are now waiting for your slide.
Can you see my slide?
Yes, I can see it. Yeah.
ภาษาอังกฤษค่ะ
Okay. The internet works all year, but at the time of the presentation, it doesn't. Okay. All right, how about now? Can you hear me?
The voice is okay, but we couldn't see the PPT.
Yeah, it's there. We can see it.
Oh, now,
You can
okay,
see the
okay, I can see it. Okay,
Okay.
please go on.
Thank you. So when you talk about dyslipidemia in Jordan, we actually have the global problem in the world. you have to look at the leading cause of morbidity and mortality, other than, of course, unwanted wars and the disasters of humans. In Jordan, the problem is similar. We have a Ministry of Health survey that shows that non-communicable diseases account for about 80% of morbidity and mortality. And from this, percent is attributable directly due to prevalence and clustering of risk factors in Jordan. This is one of the groups that work in Jordan and does research, and the JCC group actually telling you that we have some idea about the prevalence and the problem of MIs and ASCVD in young patients. And if you want to make it more interesting, you can look at the 2020 prevalence of risk factors in Jordan, showing that the distribution of hyperlipidemia is distributed. Some have severe hypercholesterolemia, some have mixed, some have low HDL. Low HDL being very prevalent in Jordan. More than half our population have low HDL, which is probably a big issue to discuss. This is the more interesting one. This is the age distribution of acute coronary syndrome patients. If you look at the patients who come to the hospital with STEMI, and you break them down to the age group, a significant portion is below 55. A lot of males below 55 come to MI, CCU, ERs, and these patients are generally undiagnosed with anything before. The first time to come to hospital is with acute MI. We estimated that our MI patients are 10 years younger than the West, meaning that we need to catch them and screen them early. If you look at the breakdown of these patients in terms of lipid disorders, you can find that a lot of them, probably 10% of them, have an LDL above 190 on presentation. And that's a problem. 10% above 190 severe hypercholesterolemia, never diagnosed in patients who are in their 20s, 30s, and 40s. And if you look at the other breakdown, below 130, about a half of them, but below 130 is not a healthy number, because if you ask the question that we asked in a study called Statin EPIC trial, we looked at patients coming with acute coronary syndrome and asked how many of those patients would have been eligible for statin if we saw them last week or last month, according to the ESC risk categories. And 7 out of 10 should have been on a statin based on their risk categories, meaning that 70% of patients who come to the hospital with acute coronary syndrome should have been on a statin before. Have they been seen by someone to screen them and to treat them, which means we are missing a lot of opportunity for prevention. So 70% of ACS patients are candidates before they come with ACS for statins. Of course, after they come for ACS, 100% candidates, because they have to be all on treatment. I'm going to move to the second part of my presentation, which is a paper we published a couple of years ago. This is the first attempt in Jordan of a consensus document from different disciplinary groups to look at dyslipidemia management. And the way we did that is we make it very simple and pragmatic. We ask the questions of, let's do it in a stepwise approach. Let's make it simple, because these are steps that the GP and internist would have to look at and proceed. We ask, well, who should you screen? Do lipid parameters, the 4 of them. Start your treatment according to the risk category of the patient. Set your target and follow up very quickly to meet that target. We did not follow the old guidelines that sometimes we're talking about and forget. We need to have a target and follow that to the max. And the way we did that is essentially adopt the very aggressive approach of dividing the patients from low risk to extremely high risk. Because in Jordan, we have some patients who are extremely high risk, whose target is below 40 milligram of LDL. And we went all the way up to 150. So if you're a low risk patient, your target is 115 or 116. Then if you're moderate, your target is 100. If you're high risk, your target is 70. If you're very high risk, your target is 55. And we included the extremely high risk for those who have indication to go below 40. And then we looked at, we have some 5 take-home messages from this paper saying that ASCVD is the leading cause of death and mortality in Jordan. It's predominantly due to clustering of risk factors and hypercholesterolemia. And we focus on LDL as our primary target because it's widely used, widely available, and it's easy to follow. I'm going to discuss the ApoB and LP little a maybe in the discussion section, but LDL is our main target so as not to dilute the message. And then we talked about looking at the screening at 20 years. We recommend national screening of everybody at age 20 because we have a lot of patients who are diagnosed with MIs in their late 20s, mid 30s, and these are previously missed opportunities. So we recommend the screening. We can discuss injectables. And we're going to reconnect in a second.
Mr. Chairman, I think we lost our speakers due to some networking problem. Hello, Dr. Mosa, we lost you. Your voice is not, he's just disappeared. He's gone.
Now?
It's okay now?
Yeah. When was the last slide you showed me?
Okay. Mr. Chang, please just show the last slide.
I'm gonna.
Oh, he's going to do it. He's going to do it.
Okay.
I can share.
Thank you. Okay.
Okay. Did we? Okay. So I need to ask you about 10 seconds if you hear my talk. Okay. So we said we need to have a set target of LDL, and then we went on to talk about triglycerides, saying below 150 it's okay. We made the point of treating triglycerides in diabetic patients who have controlled sugar, but they still have a triglycerides between 150 and 500, because we see a lot of those patients presenting with complicated issues. I know it's debatable in the literature. Of course, above 500, nobody is discussing that because you need to treat that for prevention of pancreatitis. We made a point of including fenofibrate in that. I'm going to finish with this, which is the national guidelines just released, Majority Cardiac Society. Again, very pragmatic. Very importantly, this is a joint venture between all 9 societies involved in lipids. This will allow you to have a better dissemination of the guidelines. And we said screen at age 20, look at the whole patient, examine their other parameters, blood pressure, sugar, their smoking history, which is very prevalent in Jordan, and address all these risk factors. And then we moved on to talk about ApoB and LP little a, mentioning that because it's not widely used in Jordan, but we understand the importance of this as a future direction. But we still focus on LDL. We said the option of ApoB and LP little a, especially in high-risk patients. So we have a lot of youngish population who have family history, which is strong. So I think I agree with the previous speaker about the importance of LP little a. And then we moved on to talk about discussing the risk factors and screening these patients with the risk categories and deciding what is their risk, let's say where they fall in their risk, and this is according to the guidelines. And then we moved on to talk about deciding which way to break the risk? Are you using the classical risk categories? But we also have an option of clinical risk indicators. Some of us don't like the score 2 and the score OP, but sometimes it's too complicated to calculate for GPs and attorneys. So we give the option of having a clinical assessment, low, moderate, or severe, according to the prevalence and the number of risk factors. Again, you want a pragmatic assessment for the risk. If you have no risk factors and you're young and you're low risk, if you have 1, then you're moderate. If you have 2 or 3, then you're high risk. And if you have multiple, probably you have very high risk. And we also included the extremely high risk group, which is patients who come with recurrent ACS or have multivessel disease or diabetics. These are extremely high risk and has to be very aggressively managed. So we break that down easily in the guidelines to make it simple for our patients. And we moved on to look at the stratification and deciding according to the target where you want to treat your patients. And we also break that down in a very simple way that you need to look at the differences in the regional issues. In Jordan, we have young MI patients. We have a clustering of risk factors, delayed presentation. Essentially, we need a lot of improvement for the public awareness of the importance of early screening for risk factors. A lot of people are underestimating the importance of detecting early diabetes, early hypertension, early lipid disorders, and addressing smoking. And that's one of the regional issues in Jordan that we have to tackle by disseminating the guidelines and awareness. And we mentioned that specifically in the guidelines to improve that. And we went to the stepwise approach of using statins. Again, we said high intensity statin, go aggressive. If you don't achieve the target in 4 to 6 weeks, add ezetimibe early on. If that's not the case, then you have to go for injectable. And we advocated Trasuva and Atorva as essential ones because they're the high intensity ones. We consider PCSK9 injectables in patients who have recurrent events despite statins. They have multivessel CAD and diabetics. We want to be very aggressive in treating those with injectables to achieve our target between below 55 and essentially below 40. Triglyceride, we already discussed that. The guidelines, we gave the option of fenofibrate to address those patients who still have a non-HDL that is not on target. And again, we want to talk about muscle symptoms. It's overestimated in the literature. If you open TikTok or Instagram, a lot of people will talk about muscles. They say statins will kill your muscles, destroy your muscles. We said, clearly we have still the population that muscle symptoms are largely not caused by statin. They're associated with statin. You have to look at those, screen for CK. If it's above the limit that's allowed, then you can stop it. But it's below 3 times the upper normal, we continue. We also recommend screening for vitamin D and hypothyroidism, making sure to educate the patient that not every joint that hurts is statin related, because that's important in terms of adherence. And then we have the clinical principle conclusion that the benefit of statins in cardiovascular risk reduction greatly outweighs any mild muscle issues that make the population worried about it. I would like to thank you for your attention and apologize for the technical issues. We can stop sharing now. If we're still connected.
Thank you so much, Dr. Iyas. I think you present important data from Jordan and your guideline. I think we can have some questions after all the talks, and please let our audience question lead to the panel discussion. Now we need to progress to the third talk. The third talk is given by Dr. Hanaya Munyasirinan from Thailand. She is currently Deputy Dean of Excellence, Innovation and Corporate Values Faculty, Cardiology Division, Internal Medicine Department, Faculty of Medicine, Syria Hospital, Mahidol University, located in Bangkok, Thailand. Her talk is entitled Dyslipidemia Management in Adults for Males over 40 years old and for female over 45 years old without ASCA, Preventive ASCA Risk, LDL, non-HDL goal, and the CAC score. Let's welcome Dr. Tanaya. Dr. Tanaya, please.
Hi, thank you so much for your kind introductions. Thank you, the APSC committee, for inviting me today. This is my disclaimer. So in the next 20 minutes, we will focus on adults with male more than 40 years old and female more than 45 years old without established cardiovascular disease. This group is the majority of our patients in practice. I will cover 3 important changes in 2026 ACC/AHA ADA Dyslipidemia Guidelines. First is about the new CV risk assessment score, the PREVENT ASCVD. Second is about the upgrade roles of calcium score for further cardiovascular risk assessment. And third is about the return of lipoprotein targets. So for the cardiovascular risk assessment, the PREVENT atherosclerotic cardiovascular disease has been applied for risk assessment instead of the prior pool cohort equation in the past. Risk enhancer as well as the reproductive risk markers have been revised as well. Risk assessment of the future cardiovascular disease help our decision making for approach to lipid management in primary preventions. The guideline panel's recommendation of the use of newer PREVENT ASCVD equation for estimation of 10 years and 30 years future CV events in all adults aged 30 to 79 years old without ASCVD or subclinical atherosclerosis, with the LDL between 70 to 189. The PREVENT ASCVD equations will categorize the patients into the 4 categories. First is about the low risk that have the cohort the PREVENT less than 3%, and for the borderline that have the PREVENT score. Sorry that I switched between the row. The borderline is 3 to less than 5%. Intermediate is 5 than less than 10%, and for the high is more than 10%. In general, the 10-year risk estimates from PREVENT are 40 to 50% lower than estimates from pool cohort equations in the same categories. Newer PREVENT equations have the base models considering age, sex, systolic blood pressure, total cholesterol, HDL, diabetes, current smoking, the BMI, antihypertensive, and statin treatment, as well as the eGFR into the formula. This is also optional to use the urine albumin creatinine ratio, the hemoglobin A1C, and the social deprivation index. So there are more parameters inputs into these equations when compared to the pool cohort equation in the past. This study validates the performance of PREVENT and pool cohort equation in UK populations. The subject include the participants from the UK biobanks who are free of clinical cardiovascular disease, about more than 368 people. The table displays the C statistic of PREVENT and pool cohort equation certified by sex, as well as the delta C. You can see that both equations demonstrate the higher concordance in females more than males. However, there was no significant difference found in delta C between PREVENT and pool cohort equation for either males and females. These figures in this study display the predicted 10-year risk compared to the observed 10-year events, which is designed stratified by sex. As you can see, the prevent equation is better calibrated than pool cohort equations, particularly in males and in higher risk of subjects. The pool cohort equations tend to overestimate the 10-year ASCVD risk as compared to the new prevent ASCVD equations. This is another study that validates two models in 6,000 patients from the MISA study. The observed ASCVD events, that is 6%, was closer to the predicted prevent events, that is 5.7%, than the pool cohort equation that is as high as 10.8%. Prevent was more accurate in women than the men. Calibrations of 10 years ASCVD risk was much improved in prevent as compared to pool cohort equations. And within the pool cohort equations, there is greater overestimation at higher risk patients, whereas the prevent performs more consistent across the risk spectrums. This table compares the data from pool cohort equation versus from the prevent equations. For the derivation cohort, prevent came from 130 times larger sample size when compared to pool cohort equations. The prevent came from 3.3 million US population with the 10 years younger age coverage. And the prevent also has the lower threshold in each risk categories because of 40 to 50% lower risk estimates as shown in previous slide, with the same population proportion in each categories. Moreover, for the prevent, they expand the scope of the outcomes predictions into ASCVD, the heart failure, and the total CVD that includes both ASCVD and heart failure. It also provides longer time predictions, both 10 years and 30-year risk estimations. As we know that the CV risk predictors can differ from population to population, so it's important to have our own risk score. In Thailand, we have our Thai CV risk score, which can be calculated using the lab data as in this model. Or the model without the lab. We use the waist circumference and height instead with the similar accuracy. This guideline also introduced the CPR, calculate, personalize, and reclassify framework for risk stratification. After calculate the risk categories, we personalize by discussing the risk estimate and the treatment options with our patients and relatives, as well as evaluate the risk enhancer in borderline risk group. The third step is to reclassify and reassess using calcium score in the setting of clinical or patient's uncertainty. And after that, we can decide and manage our patients. We will talk in the details later. The risk enhancer have been revised to personalize in each patient using the clinical and laboratory data, including the family history of premature ASCVD, the higher risk ethics, the high polygenic risk, cardio kidney metabolic syndrome, the chronic inflammatory disease, high CRP, the persistently high LDL, non-HDL, ApoB, and triglyceride, the high lipoprotein little a, and the reproductive risk markers. In this guideline, the reproductive risk markers have been much more emphasized in this guideline. The reproductive risk markers have been divided into pregnancy-related markers and other reproductive markers. The pregnancy-related markers include the hypertensive disorders, the gestational diabetes, small for gestational age, the preterm delivery, and recurrent spontaneous pregnancy loss. Other markers are early menarche as well as early menopause and the polycystic ovarian syndrome. In adults without ASCVD, consideration of the reproductive risk markers is reasonable to personalize ASCVD risk assessment. Second issue is about the upgrade use of calcium score for future cardiovascular risk assessment. From the previous guideline, calcium score is mentioned in these 4 situations. For the risk assessment, it is indicated only in borderline risk with factors that increase the cardiovascular risk. In this new guideline, expand the recommendation of calcium score into intermediate risk and selected borderline risk to guide decision to initiate, to withhold or postpone the statin therapy. Calcium score should be considered to guide intensity of lipid-lowering treatment in some of the intermediate and high-risk patients. In patients with intermediate or selected borderline risk who undergo the calcium score testing, if the calcium score is 0, we can defer the lipid-lowering treatment and reassess the calcium score in the next 3 to 7 years. In the setting of calcium score of 1 to 99 and less than 75 percentile, it is considered to have moderate intensity statins that can reduce the LDL more than 30% and get the goal of LDL less than 100 and non-HDL less than 130. If they have the calcium score of 100 to 299 or more than 75 percentile, lipid-lowering therapy with statins that can reduce LDL more than 50% to get the LDL goal less than 70 and non-HDL less than 100 is recommended. When we have the patients that have the calcium score of 300 to 999, the statin therapy that can reduce the LDL more than 50% to get the goal of less than 70 and non-HDL less than 100 is recommended. They also have the goal of ApoB less than 70 in this setting. And the patients who can get the more aggressive goals, the goal of LDL less than 55 and non-HDL less than 85 should be considered. However, if we got the patients that have the calcium score more than 1,000, the statins with the high potency that can reduce the LDL more than 50% to get the LDL goal less than 55 and non-HDL less than 85 is strongly recommended. The guideline also provides the guide for the condition that we can find the incidental calcium score on the non-gated CT, such as when patients went for the chest CT. If the patients have mild polycalcification, we should give the moderate intensity statin to get the LDL go less than 100 and non-HDL go less than 130. Even we found the moderate to severe calcification, the moderate to high intensity statin should be considered. So in this guideline, that have the diagram for the treatment approach as well as the LDL goal in patients with high calcium score or the calcium score of 0. The third topic is about the return of lipoprotein targets. From the 2018 ACC AHA guideline for dyslipidemia, I think everyone can remember that there is no lipoprotein target. The concept is to choose the proper statin for 4 high-risk groups, like the concept of shoot and forget. But now, in this 2026 guidelines, there is the return of the lipoprotein goals for ASCVD risk reductions, with a target of less than 100 for LDL and less than 130 for non-HDL, up to less than 55 and non-HDL of less than 85. Because in this topic, I cover about the patients without cardiovascular disease, so that is about the primary prevention. So it depends on the risk score. If the patients have the 10-year risk score from prevent ASCVD equations less than 10%, the target of the LDL should be less than 100, and the non-HDL less than 130. Whereas in the patients that have the score more than 10%, the LDL goal should be less than 70 and non-HDL goal less than 100. In Thailand, we also have our own Thai dyslipidemia guideline from the Royal College of Physicians of Thailand that coming up in 2024. We also recommend to use our Thai CV risk score to certify our patients into low, intermediate, high populations. And we also have the LDL and non-HDL targets. We mentioned about the cutoff of calcium score more than 100 as the risk enhancer. So today, I focus on 3 posts from 2026 ACC AHA ADA dyslipidemia guidelines in adults without ASCVD. To emphasize on the news of the CV risk score that is the prevent ASCVD that is more accurate than the past 2 cohort equations. Second, this guideline upgrade the use of calcium score in more population that have intermediate or have the borderline risk to guide the treatment of statin, as well as to intensify the dose of statins. And third is the return of the LDL and non-HDL targets, as well as the ApoB targets in some patients' populations. Thank you for your attention.
Thank you, Tanaya, for your excellent talk and very beautiful and very educative PPT. Thank you so much. Now we again leave the question to the end of this symposium with a panel discussion. May I invite my co-chair, Dr. Namukas, to chair the next 2 speakers.
Sure. Next, we'll have a pleasure. I'm having the pleasure of introducing Dr. Penwala Tanvir Iqbal Penwala from Malaysia. She's the consultant interventional cardiologist, internal medicine physician at the Serenba Specialist Hospital. So she'll be talking about the management of dyslipidemia in planning pregnancy and during pregnancy and lactating, and choice of timing and cholesterol lowering medications. Dr. Penwala, please.
Hi,
Hello.
or good afternoon. So I will thank you very much for the very kind introduction, Doctor. And thank you for inviting me, the APSC committee, to invite me for this talk. Okay, so I'm going to share my slides. Please confirm that you can see the slides.
Not yet, I think. Let me see. Am I?
No, not yet. I think, wait, huh? PowerPoint. Nice. Okay, I try again. This is. This is sharing. Okay, I got my slides. You can see the slides now.
Yes, looking good.
Thank you. Okay, I will make it the full screen first. Okay.
Yes, perfect.
So, thank you very much. I am Dr. Tanvir from Consultant Intervention Cardiologist from KPJ Seremban. So I was given the task today to talk about the topic, which is dyslipidemia, management of dyslipidemia in patients planning pregnancy, pregnant ladies, and lactating women. And special focus on the timing and the choice of the cholesterol lowering drug. Okay. So, yep. So this topic is increasingly important because there is increasing younger women with a high cardiovascular risk factors, and also familial hypocholesterolemia is now sometimes frequently under-recognized. There's also some confusion among physicians regarding the safety of the lipid-lowering drugs and the statins. There is a need for us to balance the safety of maternal cardiovascular risk versus fetal safety when we are considering, because once we are thinking about the mother's safety, and at the same time we need the drugs to be safe to the baby. So, and also there is limited randomized evidence available because of the lack of too much studies can be done on our pregnant ladies. Okay, so by physiological, our body tends to retain fat. The pregnant ladies' body tend to retain fat in the first trimester. So there will be, towards the end, they will release the fatty acid for the use of the fetal development. So there is physiological change in lipids. So if the cholesterol profile is checked during pregnancy, they might have some alarming results if we don't know about the the changes that happens in pregnancy. Usually the LDL cholesterol increases, the TG progressively rises, and this is all for the physiological adaptation of fetal development. And it's usually normalized by postpartum. So this is a table that shows us in triglycerides is initially in the first trimester is stable, but it significantly rises in the second trimester, but it peaks at the third trimester. However, postpartumly, it rapidly drops. Total cholesterol is also minimal change, but increased 25 to 30% in the second trimester and becomes 30 to 50% increase in third trimester. LDL remains stable in the first trimester, begins rise in the second trimester, and have 30 to 40% increase, which returns back to within 4 to 6 months. And HDLC will have slight increase in the first trimester, peaks at second trimester, but declines after in the third trimester. So how do we balance the maternal cardiovascular protection with fetal safety? We need to individualize and have multidisciplinary care, and the guidelines are recently having recommendations which are evolving rapidly. Okay. So who are considered the high-risk ladies, that are high-risk women that needs to be treated with for the hypercholesterolemia during familial hypercholesterolemias? Those with prior myocardial infarction, those with prior PCI and CABG, established SVD, means established, and then severe LDL elevation, which we mark as 4.9, and more severe would be more than 7.8, diabetes with ASVD. So how about when a lady with these conditions comes to you before pregnancy for discussion about getting pregnant? So the preconception second, we should discuss the pregnancy intention early, especially if you encounter those patients who are in the reproductive age and there is possibility they might want to get pregnant. So this should be discussed in our clinic before, and review all their lipid lowering drugs, and then contraception counseling should be given, and assess their cardiovascular risk. And also, as you have to advise for lifestyle optimization. So when should statin be stopped? The timing, yeah, we are discussing. Traditionally, it says you have to stop 1 to 3 months before conception. Avoid during pregnancy in most patients. This is also in our ESC 2019 guidelines, which says that lipid-lowering drugs should not be given if pregnancy is planned, during pregnancy, or during breastfeeding period. However, for severe FH patient, bile acid sequestrant, which are not absorbed systemically, and LDL apheresis can be considered. So drug safety overview, statins are generally avoided. Ezetimibe has limited safety data. PCSK9 has insufficient evidence. Fibrates are usually avoided unless severe hypertriglyceridemia. And bile acid sequestrant is considered the safest option. Recently, in the FDA update, there was previously there was absolute contraindication to statin use in pregnancy, but now in 2021 they had released a safety. They have released a statement. They removed the strongest warning against the cholesterol-lowering statin medicine in pregnant patients. So they are, but it is written, continuation may be considered only in selected very high-risk women, but generally it's discontinued in most pregnancy. So the one when I went through the literature review, which statin this is common, not to say commonly used, but which statin has been used is pravastatin and rosuvastatin, because they are hydrophilic and they are said to have lesser placental travel. Saying that, it is the general consensus that it is generally discontinued, but only in very highly selected cases that it can be continued with multidisciplinary discussion. So when statin must be considered is severe familial hypercholesterolemia, established severe ASVD, recurrent cardiovascular events, and this decision requires specialist care and discussion. So management of severe hypertriglyceridemia. Since we know that in the physiological side also, the hypertriglyceride will peak during the 3rd trimester. So if there is a, especially if the triglyceride is 11.3 and above, the risk of pancreatitis increase. So management is, the management that is advised is the strict dietary fat restriction, omega-3 fatty acids, and consider fibrate in only selected cases, usually 2nd trimester onwards. Also, one of the options that is then, and in literature it has been mentioned, some patients, pregnant lady, do undergo bi-weekly, means two weekly once, LDL apheresis, and it is used for severe familial hypercholesterolemia. It's extracorporeal LDL removal, and can safely be done in selected centers, in selected patients, and it requires a specialist centers who is experienced in doing this LDL apheresis. About the postpartum and lactation, breastfeeding consideration must be done. Mostly recommendation is to not allow statins during lactation and only restart statin after lactation ends. And the most safest in these cases are bile acid sequestrants. and should restart therapy earlier, depending on how is the maternal risk. So, in order to prepare this presentation, mostly I've referred to ESC recommendation, ACC AHA recommendation, National Lipid Association statements, and FDA safety update. Okay, so practical clinical algorithm is if a woman is with dyslipidemia, we have to do pregnancy planning, especially when they are in reproductive age, assess their ASVD and FH risk, review the medication, consider stopping statins, and especially review if very high risk. So it should not be managed by maybe in the primary setting. It should be referred to a tertiary center where there is a specialist review. Okay, so just to be, we can discuss some scenarios. For example, say we have a 32-year-old woman with heterozygous familial hyperlipidemia on rosuvastatin planning pregnancy. So how will we manage this patient's lipid therapy? Okay, so this is a 32-year-old woman with heterozygous familial hyper on rosuvastatin wishes to conceive. So how would you manage the lipid therapy? So suggested management is you have to do pre-conception counseling, stop statin 1 to 3 months before conception, lifestyle optimization, consider bile acid sequestrant if needed, and specialist review if very high risk for ASVD. Okay. Case 2. If we have a pregnant woman with triglyceride above 12, just now I said if it's, especially if it's above 11.3. So if it's 12, so how do you reduce the pancreatitis risk? Pregnant woman, we have scenario of pregnant woman, triglyceride 12, and concern for pancreatic risk. So we have to suggest very low fat diet, treat the secondary causes. Omega-3 fatty acids is considered safe in pregnancy if needed, and consider fibrates selectively, and also hospitalization and apheresis if severe. So key take-home message is most lipid-lowering drugs are avoided during pregnancy. Although recent FDA update says statin is no longer absolutely contraindicated, but it is only needed in very high-risk patients requiring individualized care. In some cases of pregnancy, LDL apheresis can be life-saving, and multidisciplinary management is essential. So if summarized in this slide, you can see in the first stage, which is trying to conceive, we have to optimize cardiovascular health and discontinue any lipid-lowering drugs that can have effect to the fetus. In the pregnancy stage, we have to monitor lipid level and manage with lifestyle measures. Statin and most lipid-lowering drugs are contraindicated. In the third stage, which is lactating, we prioritize heart-healthy lifestyle and consider resuming the lipid-lowering therapy compatible with breastfeeding when indicated. Okay, thank you very much.
Great. Thank you very much, Dr. Tanvir. So next is Dr. Lin. Dr. Lin Chu Feng Lin, he's from McKay Medical University from Taipei, Taiwan. He'll be talking about dyslipidemia management in patients with diabetes, with or without atherosclerotic cardiovascular disease in different age range. Dr. Lin, are you ready?
Okay, yes.
Yes, please, Dr. Lin, please.
Yes, let me show my slide. Okay. Can you see my slide?
Yes.
Okay, thank you.
Very well, yes.
Okay. Thank you for your introduction. Good afternoon, everyone. I'm Dr. Lin. I come from Taiwan, McKay Memorial Hospital. It's really my honor and pleasure to join this webinar meeting and to share with you about the new lipid guideline from ACC AHA published this year. I think this version of guideline is very comprehensive and very practical for daily clinical use. First of all, the guideline clearly defines the target population. Patients in this guideline are classified into several categories, including patients with primary prevention, patients with severe hypercholesterolemia, diabetes, and patients with subclinical atherosclerosis, hypertriglyceridemia, and patients with secondary prevention. The second, compared with the previous version, this guideline defined the treatment goal very clear. We can see that the target now include not only LDL cholesterol, but also non-HDL cholesterol. So overall, the concepts remains the same. Different strategies should be used for different risk group, and the target should be individualized based on each patient's background risk. So today, I will focus on the diabetic patient without ASCVD. As we all know, patients with diabetes have an increased risk of ASCVD. So in this population, age is the first key consideration. So let's start with the patient aged 20 to 39 years old. For patients younger than 30, the short-term incidence of ASCVD is relatively low. However, their lifetime risk of ASCVD actually gradually increase over time. So in this age group, it is reasonable to consider moderate intensity study, especially in patients with long duration of diabetes or at least one major risk enhancer. For example, diabetes, retinopathy, neuropathy, and nephropathy, or ABI less than 0.9. On the other hand, for patients older than 30, the guideline recommend calculating both 10-year and 30-year risk using the PREVENT ASCVD equation. And this equation is used to guide our treatment decision. So here is a simplified algorithm. For patients under 30, check the risk enhancers. The risk enhancers include long duration of diabetes, albuminuria, eGFR less than 60, retinopathy, neuropathy, and ABI less than 0.9. If patients have more than one risk enhancer, just start moderate intensity study. If not, just focus on lifestyle modification. For patients aged 30 to 39, just calculate the PREVENT ASCVD risk. If the 10-year risk more than 3% or 30-year risk more than 10%, consider start moderate intensity study, and this is class 2A indication. Now, we can move to patient age 40 to 75 years. This age group is generally at intermediate to high risk. So the recommendation of this guideline is to start moderate intensity study and to reach at least 30 to 49 LDL reduction. However, high-intensity study can also considered, especially in men over 50, women over 60, and 10-year ASCVD risk more than 10%. If studies are not tolerated, you can choose ezetimibe, bempedoic acid, or PCSK9 monoclonal antibodies. So we can look at the flowchart. For all diabetic patients aged 40 to 75, just start moderate intensity study first. There is also a clear treatment goal in this age group. It is LDL less than 100 and non-HDL less than 130 milligram per deciliter. And also, ApoB can be considered as an optional target. After the initial therapy, reassess the risk of patients. if the 10-year risk more than 10% over patients have multiple risk factors, just increase your statin to high-intensity statin, and the new target become more aggressive. The aggressive target changed to LDL less than 70 and the non-HDL less than 100 milligram per deciliter. Of course, if the targets are still not achieved, we can add ezetimibe or a PCSK9 monoclonal antibody. Some special consideration should be implemented. If the triglyceride level are 150 to 500, we can consider add fish oil. So overall, this age group clearly adopt a more aggressive strategy. Now we can move to patients older than 75. This patient group are still at high risk of ASCVD. However, the clinical trial evidence suggests that moderate intensity statin is usually sufficient. So here we need to carefully balance life expectancy and the potential adverse effects of patients. So in this flowchart, shared decision-making is particularly important. We just balance between patients' life expectancy and the statin-related adverse effect. So here is a clear text table in this guideline. In summary, for diabetic patients, treatment is mainly based on age group, their risk level, and how about their risk enhancers, and just calculate prevent ASCVD equation. And in most cases, moderate intensity statin is the initial therapy. So how about the treatment goal in this guideline? We can see only patients aged 40 to 75 have clearly defined LDL target. For younger or older patients, the guideline doesn't specify exact LDL target. So in clinical practice, I would suggest if you use moderate intensity statin, just reach at least 30 LDL reduction. And if you use high intensity statin, please reach at least 50 reduction of LDL. Now we can look at diabetic patient with ASCVD. I think this topic is somewhat overlap with the previous lecture, but clearly diabetes plus ASCVD event indicate a much higher risk situation. So before our treatment, there are several key principles. First, statin remains the foundation of therapy. And the second, if the targets are not achieved, please add on therapy and should not be delayed. And the third, the guideline no longer require ezetimibe before PCSK9 inhibitors. So treatment choice should depend on patient preference and the required LDL reduction. In addition, for patients with statin intolerance, we can use bempedoic acid. On the other hand, inclisiran is a PCSK9 small interference RNA and very effective to reduce LDL. However, the CV outcome result data of inclisiran still pending. Additionally, many physicians worry about very low LDL levels, especially we implement very aggressive therapy. However, evidence show that maintain LDL around 30 milligram per deciliter is very safe, even long-term for 8 years. This evidence comes from 4-year trial extension study. We can see the patient initially assigned to placebo arm finally use evolocumab can maintain low LDL for many years, and the SCVD result is very good. So the escalation is not necessary. Okay, now let's go through the treatment flow for SCVD patient. First, determine whether the patient has very high risk features. The definition of very high risk feature include more than 2 ASCVD events or patient have 1 ASCVD event in addition to more than 2 risk conditions. The major ASCVD event include recent acute coronary syndrome, myocardial infarction history, and the history of ischemic stroke, and the symptomatic PAD. The risk condition include age more than 65, and the patient have prior revascularization for his arterial disease, and the current smoker, diabetes, heart failure, hypertension, and the patient have LDL more than 100 despite aggressive therapy. For patients with very high risk, just start high intensity study, and the goal is LDL must less than 55 and the non-HDL must less than 85. If not at the goal, just add ezetimibe or PCSK9 monoclonal antibody. Of course, you can consider inclisiran, and you can consider bempedoic acid if still not at goal. For patients not at very high risk, the strategy is very similar, but the target is slightly different. The target for patients at high risk, not very high risk, the goal is LDL less than 70 and the non-HDL less 100 milligram per deciliter. And the escalation strategy remains the same. Finally, I will show you the Taiwan guideline for secondary prevention and the primary prevention. Regarding patients with secondary prevention, the LDL target is at least less than 70. However, some patients with very high risk features should be monitored, especially the patient with CAD or ACS and diabetes, or the patient have recent MI within 12 months, or the patient have 2 prior myocardial infarction, or the patient have multivessel CAD, or the patient have other arterial disease, especially concomitant PAD. The LDL target less than 55 can be considered. And regarding the patient with primary prevention, the Taiwan lipid guideline declared some patients should be monitored if especially the patient with very high risk features. In the primary prevention, if a patient have DM, CKD, or the baseline LDL more than 190, we define this patient have very high risk feature. And just start lipid lowering therapy, and the LDL target should be less than 100. If no, we can check the 6 risk factors for patients. The 6 risk factors include hypertension, and the age, and the premature family history of CAD, and the HDL level, and the current smoking or metabolic syndrome. If the patient have more than 2 risk factors, the LDL should be less than 115. If the patient have just 1 risk factor, the LDL target should be less than 130. So I think the lipid guideline in Taiwan irrespective of primary prevention or secondary prevention, is very clear. So finally, this is my take-home message. In the new guideline from ACC AHA, risk category is very important. For diabetes with primary prevention, we must consider patient's age and check the risk enhancers and calculate prevent ASCVD. The initial therapy is moderate intensity statin and escalate to high intensity statin if needed. For secondary prevention patient, just start high intensity statin and check the very high risk features. The treatment target is very clear. For very high risk patient, LDL should be less than 55 and the non-HDL should be less than 85. And for patient not at very high risk, the LDL should be less than 70 and the non-HDL should be less than 100. Also, we can use some non-statin therapies, including ezetimibe, PCSK9 monoclonal antibody, and the small interference RNA inclisiran, and the bempedoic acid. And importantly, very low LDL, around 30 milligram per deciliter, is safe in clinical evidence. Finally, I would like to mention about some limitation in this version of guideline. First, the prevent ASCVD equation may not be fully applicable to all population. So, second, drug availability and the reimbursement is quite different across countries. So in practice, the guideline should always modify to local clinical setting. This is my short talk today. Thank you very much.
Thank you very much, Dr. Lin. That was great. Actually, I was having a question, but I think your last slide just answered all the questions I had. Whether the guidelines from America would be applicable to the Asia Pacific regions. You know, I really love Dr. Musa's guideline with the screening of a 20 years old patient. Certainly, that will be a different population compared to the Asia Pacific or the ASEAN region. A question I have was, so will there be any age you will not start statins? 90 years old?
Who are you asking, Dr. Tachapong?
Oh. Anyone.
Okay.
Anyone.
No, I'm fine with I don't think age is an issue. It's just an indication, and as long as the benefit outweighs the risk.
Sure.
So may I just ask one question just regarding the age? Because all the speakers, they cover different age range, but for women, it's over 45 and then 19 to 39. How about for women 40 to 45? Who will answer this question?
Yeah, missing from the group.
Yeah. I just wonder, maybe Dr. Tanya, maybe Tanaya, maybe you can have some suggestion, because the age just missed the woman between 40 to 45. How do you think?
Yes, I'm think that maybe the reason they get the higher age for women, maybe because the risk is lower, I mean, before the menopause. I think so that is the reason why women set the age of 45 to get like the prevent ASCVD. But I agree that, I mean, it depends on the risk of of themselves, like for the women that have the strong medical history of premature ASCVD, or the patients that have, very, very high LDL or another risk factors. We can do the screening earlier. And back to the question of Dr. Tachapong about the upper limit of the age. I think I'm agree that there is no like upper limit, but for the range of screening, it depends on the cohort data that they have just only to 79. But now it's like the aging society. So in many studies, they also include the patient up to 90. So in the elderly, maybe we need to wait about the benefit and the risk of the patients, because sometimes in the elderly, they have like the liver disease or the renal disease that have like the something that can cause the side effect from the treatment. Yeah.
I have another question for Dr. Thananya, since you're here. Now, when do we do a follow-up calcium score? Let's say if it's 99 now, when do we check if we have to go up?
Yeah, I think it's the difficult questions, and there's no like the definite guidelines, but if depends on this 2026 guideline, they mention the period of follow-up just only in the patients that have the 0 calcium score. They mention that in the patient who have the 0 calcium score of 0, maybe we need to follow up about 3 to 7 years after this. But I think in the patients that already have the calcium already, I think it depends on if we follow up, do we change the management? If we think that they already get the good target with good drugs already, for me, I did not follow up the calcium, but in the patient like the LDL goal is now 70, but we think that if the calcium is much more higher, we will like get it lower to 55. Maybe that is the patients that we would do it. Yeah. So it depends on if you change management or not. Yeah.
Anyone else want to give us the answer to this one?
Yeah, can I comment on that?
Sure. Dr. Musa, please.
From Jordan. Yeah,
yes.
I take the calcium score with a grain of salt, because we have a young population who have MIs. Actually, in one study, we looked at calcium score of 0, and we found that anywhere between 10 to 12% of these patients have plaques when they do CT angiograms. So you can have young population with non-calcified plaques that will have a score of 0 and still have plaques that are a potential culprit for MIs. So I look at the calcium score in the context of the risk factors. If somebody has an LDL between 160 and 190, and his calcium score is 0, and he's a young patient who's likely to be a smoker in Jordan, I would probably start him on statins. Although the guidelines say, well, if your calcium score is 0, then you can hold off the statins. I don't do that in my patients, because I've seen young patients with acute MIs who have non-calcified plaques, and these are missed opportunities for prevention.
I love Jordanian guidelines, by the way. It looks very simple.
I also
Taiwanese guideline too.
Yeah. I also like to comment this. I think for calcium score, it's just to add on the risk, but not to exclude the risk. So in Taiwan, if a patient with calcium score is 0, we just don't think he is safe, but rather if he has calcium score more than 400, actually we think he's high risk. So actually we use calcium score to add on the risk, not to exclude the risk. Because as Dr. Amosa said, so many people with calcium score 0, but actually they have vulnerable plaque. Just because their plaque have no calcium, you cannot detect them, but it doesn't mean they don't have risk. That's my comment. Thank you.
Yes, and one more point, if I may. We observe some patients who actually have an increased calcium score after statin. You start them on a statin, and then the calcium score goes up. And in this group, sometimes if you restudied them with a CT angio, you look at the composition of the plaques, you find that the plaque has less lipid core and more calcium and the fibrous cap. So sometimes statins will increase the calcification of individual plaques because of the, I would say, stabilization, and that's one of the components. So calcium score should be taken as a part of the big picture, not the whole picture.
Yes, I agree.
I also agree. If a patient is smoker and hypertension and calcium score is 0, but we know that he's an active smoker and he most probably is not going to quit. So we still have to keep him on statins. I agree with Dr. Yes about this.
Thank you.
So another question, may I? I have a lot of questions. Dr. Jia, for the LP little a, if we have not reached, because in Thailand it's not reimbursable to get this blood test, I think. So I mean, if we have not reached the LDL goal yet, should we make the patient pay for the test? What do you think?
Well, I think it is irrelevant about whether you reach LDL goal. I think everyone should be tested LPA. So especially if they already had a heart attack or they already have ASCVD or very high risk to have it in the next 5-10 years, then all the more they should have LPA tested. So use it as a cardiovascular risk enhancer, use it to motivate the patient to lower the LDL, telling them it's genetic. So most people are willing to do that. A simple way to remember what to do for LP is LILAC. So I actually do teach a lot about that. It's a LILAC method. You just have to remember 5 things what to do. And the first one is to use LPA as and other risk enhancer together, and then that can use prediction tool. I will be to improve the overall risk, tell them not to smoke, control blood pressure, and so forth. L is to lower your LDL down to the target that you want. But if the LP is very, very high, let's say in the 400-500 nanomole per liter, I do push even lower the LDL for people who are high risk, because the LPA that's about 400 and above is pretty much similar to a FH. Then A assessment and C is cascade. So so there's a lot of things to do, and I definitely think, and I heard that the Thailand, some hospitals are doing actively already.
Yes, private ones, but not government ones.
I see. Yeah.
Maybe I can share the experience in Taiwan.
Please.
In Taiwan, our government, the national health system just reimburse once for lipoprotein little a once in his life or in her life. That's a very unique reimbursement policy.
In Jordan, it's not widely used, but we're moving towards using it more and more because we have the strains of familial CAD at a younger age. So we're trying to consider it as part of the screening method, but it's not mainstream yet.
Well, Professor Ye, are we out of time? Or we have more time for questions?
May I ask Dr. Lo Wan, because she mentioned in Singapore, actually the young age people have high prevalence of unrecognized dyslipidemia. So what would you think, what's the best way to solve this problem?
Well, the government solved this problem for the men because Singapore, like Taiwan, is compulsory for men to do national service. So all the men are now screened for cholesterol levels when they enter national service at 18 years old. But for the women, then, no one screens them until they're pregnant, right? So then there is an awareness issue that women do not know, because the old thinking is that we wait till 40 to check cholesterol, blood pressure, and diabetes. But I think that's just too late now if you want to do a 40-year-old.
Okay. In Taiwan, the situation is a bit different because for our university new students or university newcomer, the government ask every student need to have a blood test before entry, and the blood test include cholesterol. But the problem is not actually just they see the data, but they didn't follow up the data. It's our problem now. So for your country, your government have for the army service male, they have the
follow-up.
they have regular follow-up.
Yeah, so in fact, it's a bit of a problem because when their cholesterol is high, then they automatically are not allowed to exercise because they are afraid that they will have a heart attack, during their national service. So what happens is that when they are picked up to have LDL that's more than 4.5 or 5, they will go straight to see a cardiology or endocrine or lipid service, and then they will have a whole series of tests. And then if they are diagnosed to have FH, then usually they are not allowed to do extreme exercise also. So, but they're actually young and fit. So, but at least that helps the treatment and awareness. Yeah.
Okay, that's a good point. Thank you.
No, thanks. Good question, actually.
Maybe I can ask another question regarding a pregnant woman, because the pregnant woman, when they have hyperlipidemia, actually the new recommendation is stop the study 3 months prior to the delivery. So in the real world, because I'm not a woman doctor, but I don't have such experience. How about your experience in each country?
1 to 3 months prior to conception. Not delivery, but they say that minimum 1 month, more recommended is 3 months before conception. Those ladies who are already on follow-up, maybe on a already known case of ASB, CVD and all, but selected also familial hyperlipidemia cases, or some patients are already dyslipidemia patients. At the age of 30 something, they already have dyslipidemia, so they are recommended to stop 1 to 3 months if they are planning for pregnancy.
Okay. And how about in Thailand? Maybe Dr. Tanaya, what's your experience for your country guideline?
Yeah, I think I'm not sure about the guideline, but for my practice, usually we discuss about the risk benefit with the mother, and because actually that patient should have like very high we stop it before the conception, maybe about the same period, like 1 month. But I think for the practice, sometimes it's difficult because if like the natural conception, sometimes we did not know the exactly timing that they will pregnant. Sometimes we stop like more than like 1 year, but they're still not pregnant. It's easy for us if they have like the IVF or something like that. So we know the exact period. Yeah. So sometimes we stop for a long time, and we know that the longer we stop the medication, the increased risk of atherosclerosis.
Okay, thank you. And how about the situation in Singapore?
So it's true that FDA, removed the contraindication as a strict contraindication for statin in pregnancy. But the problem is that, the complaint rate is so high, and the possible being sued, to doctors, right, is very high if there was any problem with the baby. So a lot of doctors are not willing to give, even specialists don't give statins in 2nd or 3rd trimester. I must say I've only given even once or twice, for the 2nd, 3rd trimester, only because it was really super high risk, like a person already has stent and heart attack before, or another person who had recurrent pancreatitis from high TG, because it's just so difficult to have the risk-benefit discussion at every month to a pregnant woman about this. So, I think it's very difficult, and looking at the observational data that statins are safe in pregnancy is still not enough to give a lot of people assurance that even doctors, right, to say that we can give in pregnancy. Then the problem is breastfeeding also. So for a lot of women, they breastfeed for a long time. Sometimes it's 2-3 years of breastfeeding, and then sometimes it's just latching at the middle of the night with not real large amount of milk, but yet it's still considered breastfeeding. So it makes it a really hard thing to do about when can you really start statin and when can we tell a patient to stop breastfeeding. So it's such a difficult real life situation, isn't it? Yeah.
Okay, thank you. How about Dr. Amusa? How about the situation in Jordan? If you encounter a woman with acute myocardial infarction and maybe due to heavy smoking and just age 40, how would you do?
In terms of pregnancy?
Yeah.
Well, that's a tough question. If she had an MI and she wants to get pregnant after that, then we have to have a long discussion about the danger of stopping statin during pregnancy. I had a couple of patients, I stopped the statin and she got pregnant, and then I said, okay, well, after you deliver, no breastfeeding, and you're going to be back on statin immediately. And I had a patient who refused actually to stop statin, and she continued to be pregnant because she said, I don't want to get an MI and die and not raise my kids. So she kept on a statin and she delivered and she was okay. So it's an individualized discussion. But initially I tell them, listen, if she's youngish and she wants to get a couple of kids, get these kids as soon as possible so you can, just do some tubal ligation, and then we can put you on statin for the rest of your life. But we have to do it. This is case-by-case discussion.
Okay, thank you. How about Dr. Zhao Fengling? In your daily practice, have you encountered a woman at this age, and what's your suggestion?
Okay, you mean a pregnant woman with myocardial infarction or dyslipidemia?
Or a young woman with myocardial infarction and want to be pregnant. What's your opinion?
Yeah, this is a very difficult situation because myocardial infarction will cause cardiac death. So after discussion with family, almost all families agree to coronary revascularization for the pregnant woman with myocardial infarction. However, the doctors cannot be sure the safety of the fetus. So I think the risk and the benefit should be explained before our procedure to patient and the family. However, in Taiwan, almost the family or patient want to maybe agree to the invasive procedure because the procedure may be short time and very quickly, and sometimes low dose of contrast, so relatively safe than the previous age. So I think this is the current status in Taiwan.
Thank you. I have no more questions. Maybe leave it to Dr. Tachopong.
Pretty much out of questions. I'm trying to look to see what else I had put down. Well, maybe I'll go back to Dr. Jia again. So it seems like we started, the title was 16 to 29 years old. So I'm wondering, I mean, the pediatric screen kids with high cholesterol, and what between the age, that age between the pediatrician and the cardiologist or internal medicine, there's a little.
So the question of interest is, when should children start checking their lipids, right? So I mean, Americans, like the National Lipid Association of America, they do promote 9 to 11 years old as the age of testing for all children. And especially, of course, if there was a family history of heart attack, stroke, then 9 maybe even too late, they would want to go even earlier. But that's a bit harsh and difficult in Asia setting to be so young. That's the age also that our children are having exams, and in Singapore, the big one is called PSLE, so it's very stressful. Then that's not when we want to do cholesterol check. But we do actively tell patients to test for familial hypercholesterolemia at that age, when one of the parent has that. If both parents have suspected heterozygous form of familial hypercholesterolemia, then actually test earlier at 2 years old would be good even. So, but as to the primary care testing children, they are not doing it, and that's not routine. Definitely not part of any public or private service. We don't do that. Yeah. But do any of your country do such young age for routine screening?
Dr. Musa in Jordan, they do 20 years old. When do you
20
start
and
treatment, Dr. Musa? Yes.
Yeah, we start treatment at 20. It's fine. If somebody has an LDL that needs treated, we give him or give
20 is
her
fine,
statin
but
at 20.
pediatric, 20 is adult, right? 20 can go.
Pediatrics, we had this discussion with the pediatric cardiologists, and some of them were proposing as early as 5 if there's a family history.
Wow.
And I said 5. I mean, that's traumatic for everybody to get a kid, say you're having high cholesterol at age 5. But sometimes you have to face it. If the family history is strong, we have some families with really like an LDL of 600-700 in the mother. And we screen, we send them to the pediatric cardiologist and say, you deal with that. And they would screen them at age 5. The problem is what to do with that if you find it. And they would say also some of them are using statin in a younger population. I'm not sure about the cutoff point for pediatrics, but you can start it at a younger age. But that's a tough situation. That's why I'm an adult cardiologist, because I can't deal with sick kids objectively.
I guess add statins to milk.
Yeah, right. High intensity.
Yes. Forget about low fat, or just add statins too.
Yes. And I can comment a little bit about the females between 40 and 45 because there is a gap in the guidelines. I think the risk is a continuous variable, and that's why we should deal with it as such. It's not categorical. I mean, you don't get more risky when you're your 40th birthday. So I look at the risk as a continuous process, and I blur the lines between what the guidelines say 40 to 75. I think that's just very arbitrary. And I think you just have to deal with the patient regardless of their age. If they're 21 or they're 91, I think either one of them is a candidate for proper therapy, because we have a 91-year-old who's really young looking and living his life, and we have a 25 who feels like he's 90.
May
So
I
look
ask?
at the risk as non-categorical variable and treat as such regardless of the cutoff that the guidelines have.
I mean, let me ask everyone else. What's your viewpoint on the next step? Let's say the PCSK9 or ezetimibe. Given that each country has different reimbursement scheme, but let's say without the reimbursement scheme, I mean, what would you recommend someone like me? Do we go ahead with the injectables, or try ezetimibe first for all these speakers?
Yeah, I can answer that. In Jordan, we immediately recommend ezetimibe if the target is not achieved, knowing that ezetimibe will give you about a 20% additional reduction. And ezetimibe is very, very cheap in Jordan. We have actually a fixed combination of statin and ezetimibe that has the same cost as statin itself. So adding ezetimibe to statin doesn't really add any additional cost, because we have the fixed dose combination of rosuvastatin and ezetimibe. So that will be our goal. And sometimes we actually recommend starting that combination. If the patient target is more than you expect with statin alone, we said, okay, we'll start the combination from day one. And we call that high-intensity therapy, not high-intensity statin. Our post-MI patients are routinely given a combination of rosuva and ezetimibe on day one of admission. When they come to the cath lab with STEMI, you open the vessel and then they go to the CCU, and the resident knows that he or she should start them on something like rosuva 40 plus 10 ezetimibe right away, because you want to get their LDL down to below 55. And the average LDL in acute MI patients in Jordan is 130. So you know with high-intensity statin alone, you will not go below 55. So we add ezetimibe liberally. And if they're not controlled with that, then we consider PCSK9, which is very expensive in Jordan. The inclisiran costs about $2,000 per injection, and the PCSK9 monoclonal antibody costs about $700 a month. So it is the costly, and the reimbursement is an issue.
Same thing in Thailand, I think.
Yes, the same situation in Taiwan. Although it's cheaper compared to Jordan or to Thailand, but still, if you ask patients to pay for themselves, I think you will feel they are mostly reluctant. But if you add ezetimibe, actually everybody is happy. The problem is it maybe not reach the target for their goal. But I think nowadays our government try to lower the price of PCSK9 antibody as well as inclisiran. Maybe later, if the pharmaceutical company agree to reduce their price, the reimbursement will be more friendly and more practical.
Yes.
In Malaysia also, the issue is with the cost of the cost of the PCSK9. So usually we'll just go for statin and then add on ezetimibe when needed. And PCSK is for the high-risk post-MI patient. Some get reimbursement because their company insurance cover that. Then it's possible in post-MI, in selected cases, we can give PCSK9. But mostly, most people cannot afford the PCSK9, except they are very VIP and they can afford. And they are intolerant to statin and they're willing to pay.
So in Singapore, for 1.5 years now, the government has subsidized the cost of evolocumab, only evolocumab. So it's quite cheap now. It's about 100 Sing dollar a month for Singaporeans. So that is like, less than, that's like what, 80 USD, per month. So it's very cheap. But because it's an injectable, so the take-up rate is still not very high. You mostly are people who had heart attack and they're scared of another one, then they would do. But people as a primary prevention, a lot of people do not want to take it. Yeah. So we are still, So I think the oral PCSK9 that the Coral Reef studies show is quite promising. The oral tablet and enlicitide, we'll see whether if that comes on board, more people are willing to take.
Wait, where's Mr. Chairman?
So I'm here. Okay.
So, hi, Dr. Ye.
Yeah. So I think we have actually very warm discussion regarding the topic today. Actually, I think our speaker just speak very clearly, and we discuss a lot of practical issues during our webinar. Maybe if there is no question from the audience, maybe Dr. touch upon, maybe you can have a closing remark.
Oh, I usually give short remarks. People in Thailand knows. I just say thank you very much for all the speakers and all the people who attend the webinars. So APSC really appreciates everyone to work on this. I at least myself learned a lot today. So without further ado, thank you very much for everyone to join us today. See you at the next cloud webinar. Thank you very much. Bye.
Thank you.
Thank
Bye-bye.
you for all.
Thank
Bye-bye.
you. Bye-bye.